I hope so. Yeah. Yeah, thanks first for the invitation. Just kind of, I think if there's a spectrum of emerging cases, this is really far on the end of just beyond a glimmer in the eye, basically. Maybe I'm being a bit too hard. Keep that in mind. And I guess the Buddha might be a little disappointed. In other words, it's just an idea. No, there's one case I'll talk to you about that has started, and then the first bit that I'll start with is really some ideas that are at the grant planning stage. And the theme here, as the title is, movement assessment and rehabilitation with wearable sensors and immersive technologies. So you'll see I'll start out with talking about the technology in each case. And there's really two different technologies that I'll talk about that we're excited about. This is kind of a image that I think captures the program, our research program, rather well. You know, basic scientists, we're always going to be basic scientists, but increasingly, as Paloma suggested, I'm trying to find ways to steer the basic science to make contact with clinical problems. And that often, as is the case with these ideas here today, involves harnessing technologies to bring to bear our science onto these clinical problems. So that's really where we're at, right? And I'm to put it frankly, I just would not be satisfied if I don't get there. So before I'm done, I need to get there. If that, it's a little bit dramatic, but yeah. So this is the technology I want to talk about first. It's really simple technology, but I think a couple of points I want to make about it. One is that it's been around since the initial publication in stroke research was in 2000. And this person, Catherine Lang, I'll give a quote from Catherine Lang next. She's been doing it at her lab, leading the field here for the last decade or so, really championing this stuff. And it's a really simple device, accelerometer. You can wear it for upper limb assessment. You can wear it on the wrists, like what's shown here. And these are two commercially available devices. Here's the quote I was talking about. There's a wonderful review piece here that really captures the state of the field and identifies a lot of barriers and benchmarks moving forward. And it's incredibly, incredibly useful. I could spend the entire time talking about that paper. So people seek physical rehabilitation services to improve their movement in daily life. So rehabilitation professionals need a way to quantify that movement in order to best help their patients. So Catherine, even from the very first publications from her group, I'll show you a little bit of this. She distinguishes, this is from the World International Classification System, WHO, where they talk about, performance versus capacity, right? And capacity is measured in the lab or in the clinic, structured way, whereas performance is something that captures, everyday life. And that's what these instruments promise. We're really in its infancy right now, but they promise this kind of objective way of evaluating movement in everyday life. So here's publication. It's 2015 from her group. I'm not going to get into the details of the measure. I really just want to kind of give you a sort of qualitative impression that's enough for us because we got to move along. So if I toggle back and forth here, what you should see is these kinds, there's symmetry here, right? You just take it for a moment as that. And the symmetry is kind of broken here. So this is all healthy controls. They're wearing these devices for a number of days, going about their daily activities, right? Unstructured. And the key, I can say this much, it's really important. The advantage is that if you quantify movement across the limbs here, so you have a baked-in control because you're actually, this measurement here really reflects the extent to which people are using both hands. And the more the teardrop aligns with that 0 on the x-axis, the more people are using both hands in what they're doing. And what you see is that collapses in stroke survivors. So the folks on your far left here, you see this kind of asymmetry in the cloud, right? And that just reflects more use of the unimpaired hand. So in their daily activities, they're using their unimpaired limb much more than the impaired limb. And it tracks roughly with a clinical assessment known as the Action Research Arm Test, the ARAT. However, what's interesting, right, is the Action Research Arm Test is a measure of capacity done in the clinic, right, or in the lab. And one of the things that was revealed here is that the middle individual, and this is just one example, has more capacity than they seem to be taking advantage of in their everyday life. There's a disconnect between their performance and their capacity that calls into question potentially the validity of the measurements. I mean, put it this way, if you see a change, and if an intervention changes something on a clinical test, but it doesn't translate to anything the person's doing with their hands at home, how valuable is that, right? And so this is an inroad into addressing this. Now, I want to shift gears a little bit, and because this has been developed so well in stroke survivors, and in Parkinson's, actually, there's an opportunity here to move it towards more of what we've been concentrating on in the last decade or so in our lab. And that is the case of hand nerve injuries. So in particular, what I've got up here is just giving you a sense of the scope and significance of this problem, where specifically this is when you've had a cut to one of the major nerves of the hand that requires a surgical repair. There's lots of different kinds of hand injuries that could apply to this, for which this technology could help. But I'm just putting up the information here. The points are that it's extremely common. About 10,000 individuals per year have one of these accidents in the UK, and it's extremely costly. So the functional consequences are profound. If you have an injury like this in adulthood, the impairments are indefinite, sensory, motor, often pain for the rest of your life. You don't regain full function, and the consequences economically are really startling. Right? There's a lot of loss of work, and so the health economics on this are, if you do the math, you're talking about roughly 190 million annually to the UK, and that's conservative based on the data that we have. So what? So what can we use this stuff for? We can characterize recovery, right? And that's what's been done in the stroke world. Recovery profiling, condition monitoring, evaluating against in-clinic or in-lab assessments. That's useful too, this idea of the separation between capacity, performance. So that's been done. And you evaluate treatment efficacy. You can use it to evaluate treatment efficacy. So the way that it maps onto hand nerve injuries, I think it's kind of obvious. The time course of this is such that you kind of live a one-handed life after one of these injuries for a while. And good recovery looks like a return to bimanual life. So there's a fit here between the analytical tools that have been developed in other conditions to this. This is a James Lind Alliance partnership. I think it's maybe even a decade ago. They came together with the British Society for Surgery of the Hand, identified this as a major priority. They did this year-long, I think it was a Delphi-type process, a consensus building across patients, carers, healthcare professionals, and they came down to the top 10. And of the top 10, there's two that really talk about, hey, we need to know what treatments are good here for these kinds of problems. So there's a precedent. And then finally, it's just worth noting that we are well poised to now scale it up if we can get this stuff going. So this reflects our networks. So we have networks locally, but also some major trauma centers in Wythenshawe, now in University of Birmingham, and also now in Nottingham. Just to give you a sense of it, at Wythenshawe alone, they do about 2,700 repairs annually. So it's major. And so you could potentially scale this up. Remember that one of the advantages here is that this stuff can be used remotely. You can mail it out and receive it again, all the data. My former supervisor as a postdoc, has done some of this work with amputees where he's developed the protocols to mail out the instruments, get the data, get it back. So you can kind of get it across multiple centers at a large scale. I've got Professor Sue Francis noted here because we're building a UKRI grant together where we've got some functional brain imaging across centers. We've got the exact same 3T as they do. So, I won't talk about this stuff, but, there's a branch to this that's mapping the brain, if you like, mapping the hand. That's led by Dr. Andrew Marshall, who is an expert in microneurography, which is a really useful tool for mapping changes in the peripheral nerves, right? And so there's a regrowth process. Mapping the brain, mapping the hand, mapping recovery is that third branch of the grant that will involve, hopefully, the methods that I just shared with you. I realize it's fairly broad brushes here, but those are the ideas I wanted to convey as a kind of big picture, and then I'll dive into an actual case that we've actually started some work on. So this started in October, and we received some funding for a PhD, and Ronan is here today. Ronan is the appointed PhD that will lead the work with a team that involves Carl Jackson, who's leading the inpatient stroke center in Carnarvon. Giovanni will be the second supervisor, or is the second supervisor. And Gavin Buckingham from Exeter has a lot of experience with VR. So you'll see in a moment the technology now. I'm shifting a little bit to immersive reality. In a moment I'll show you the tech. So Gavin has a lot of experience from a movement science background, like myself, using this stuff in the experimental setting. We've also partnered with a company called Rescape, who's a Wales-based company. Their home office is in Cardiff. They are the first to develop an immersive reality medical grade product, and they've been working thus far in a different area, anxiety, treatment of pain as well. So I've coaxed them into coming into the world of upper limb. And so I really want to just stress that this project wouldn't be possible without this inpatient stroke center. And this is the team here, Carl, and we've worked most closely with Helen. I mean, this is just an amazing resource that we have. We've been meeting with them and talking with them. They're very keen to get involved in research. And the kind of resources that they have, the kind of space that they have, and their time to be able to integrate into our research ideas is really, really exceptional. It's a special thing. And that's what I think makes this all possible. So this is the technology. I'm going to talk about the MetaQuest. It's called the MetaQuest 3 now. And so I want to say a couple of things. One is about its hand tracking capability. And the other is about this, what they call pass-through. And basically, I'll show you a little video of the pass-through first. So this is just Ronan with our headset up in his office in Brigantia. And I just want to show you, what this looks like. So you wear it and you can record what you're doing, what you're seeing, right? And you can see the world as it is. So a patient like a stroke survivor doesn't have to be immersed fully. And I think this has its advantages. For example, safety concerns, right? You don't want them bumping into things if you immerse them entirely. And it also tracks the hand. So you can record what's going on and get all the data with respect to the hand movements. So just keep that in mind as I bring that back up in a moment. I'll show you one other video, just very, very briefly. This gives you a sense of the capabilities at this point. If it launches. Right. So let me just skip to a part where it's sort of doing some cool stuff. So you can see what the hand's actually doing, and then what the representation of the hand. So this is I always want to say Oculus. That was the old name before Meta bought this out. This is a Quest. This is a Quest 2. So Quest 3 is actually better than this now. So, from a movement science perspective, from a person that's interested in getting into, evaluating impairment, helping out here with people with hand problems with their hands, it's super exciting, right? And the technology is moving in astonishing leaps and bounds, so that it's getting better and better and better. I mean, what the future looks like here is being able to actually track movements with this device. And I think that has such implications for assessment, diagnosis, condition monitoring, rehab, you name it. I mean, it's amazing. At the moment, this is a paper that evaluates its accuracy. So at the moment, this is Quest 2, the earlier version. It's not perfect, but as the authors themselves say, here's the quote, "If the emphasis is on rehabilitation and encouraging the use of the hands, then the consequences of accurate measurement may not be of such importance." So there is some error. The error is worse in the periphery. So it depends on your goals, right? So let me talk a little bit about the project itself. So gaming and rehab and stroke, it's been around. Lots of people are working on it. Increased engagement, fun, that stuff's been kind of well documented. Rehab at home, reducing the burdens. So there's actual sustainability implications here, right? Because there's an environmental footprint that you can reduce by potentially having patients not have to travel to the clinics and rather do their rehab from home. Our approach, where we're coming at this, is to target upstream processes. Rather than just focusing on the movements themselves, we're going to target the choice, the selection component. A bit of work that I've been up to for a long time, for a while now. This is a collection of papers, all thematically linked. Talk about underpinning research. This comes from Bangor. So we've done stuff behaviorally, brought it into the scanner. Then behaviorally again, brought it back into our scanner, then did some TMS. I won't talk about this much, but I want to show you a paradigm that we're going to use and make a point about where we're going to extract the knowledge that we've gained and try to plug it into the development of the games. So it's really simple. So measuring hand choice. Here's a paradigm we've worked with across 3 papers now, 3 of those papers in different variations. Super simple. You just reach towards visual targets. You can use either hand to do that, intercept the targets. And if you present the targets so that some of them are on the right-hand side, some on the left-hand side, and you just plot which hand is used to intercept the targets, you get something that looks like this. Not surprisingly, pretty intuitive. When the targets are on the left side of space, the person uses their left hand. This is an individual's data. So what, right? What does this do for us? You can fit a curve to it, a function to it, and describe it in terms of those are the properties of that curve. And one of the measurements that's of interest here is this point of subjective equality, which is a theoretical point in space. So space is on this axis here, and this is simply the proportion of hand use. This is the theoretical point in space where either hand is equally likely to be used, right? And you still might be asking, so what? So there's 2 points here. This paradigm provides benchmarks for validation, and it also, these measurements are individual level and sensitive to change. I'll show you a demonstration of that in a second. So the first work we need to do is to validate the platform itself. That is to demonstrate that the principles from the literature, some of which we have been involved with establishing ourselves, transfer over to this, right? We think they will, but we need to do the work to show that. So here's one of those anchor points. If you measure the time that an individual takes to move, so their response time, if you like, I like to call that time to movement onset in this context, but if you measure that time, what you see is that people take longer to respond to targets near the PSE, near the point of subjective equality. Think about it like there's some ambiguity there. I could use either hand. So this is a kind of signature of the choice costs. And this is a different score. If you subtract the choice minus if you do a task like this where you predetermine or you instruct them to use a given hand, you don't see this effect. In other words, the effect reflects the decision time. And it's a very robust effect that we've found across paradigms. You can see here, this essentially shows that every single individual, I think there were 36 in this particular study, showed the effect. So that's relevant because it's an anchor point for us. When we move it into augmented reality, we can use that to validate that everything is going as we think it should. Okay, this is an individual's data, as I said before. You can fit the curve to it. This is the same individual under different conditions. So not so important what the conditions are here. What this was simply, you do a lot of trials. You do like 800 reaches in this. And all we did was sort the ones that involved a left hand before their trial versus a right hand. So you sort the data according to recent history. And actually what we found was recent history has an effect, a motor priming effect, if you like. So people are more likely to use their left hand to reach the same part of space if their recent history involved a left hand use. This is incredibly sensitive, is what I want to communicate, is that the measure is sensitive to change. Here's another individual showing you that the characteristics of the function are unique. Right? And I'll just move along quickly because I think I probably need to do that. I didn't actually track that. So hopefully that makes sense about those two characteristics of the data that will be useful for us in this first phase. But you still might be saying, so what? So here's another idea, right? Where what if you, unbeknownst to the participant, change what gamers call the hitbox? So the size of the hitbox, the accuracy requirements, if you like. And you make it so that one hand is the success of one hand is more likely. What you predict is that you would shift this hand choice behavior. And this has actually been demonstrated by Richard Ivory's lab in the field. So what hasn't been explored is, now imagine that where you manipulate reward value, like say the game points, for example. So I hope you can see where we're going here. We want to first explore what game features influence hand choice in a very empirical, experimental way. Then we want to use this information to dynamically alter hand choice and to design games for stroke patients. So you could imagine here, right, making that every time their affected limb goes to reach, you make it the point outcomes much more higher, and the success likelihood, and so on and so forth. Whatever features we determine are useful. So these are the outcomes. One is a really basic scientist outcome, basic science, greater understanding the principles. One is kind of innovation, and the other one is a proof of concept with our collaborators. So in terms of impact acceleration, there are some points to be made here. We want to not do this serially, right? We want to do this in parallel. We want to have input from patients. We want to get some technology deployed in the clinic right away so that we can have a look at routine therapy, the movements that are going on in routine therapy, have the principles of rehab science inform our game design, have patient input inform our game design. So we'll develop some interviews, some questionnaires, some materials that we can maybe even expand out to networks to get some questions like, how likely would you be to use such technology? What kind of games would you be into? That kind of thing. Then we really, in keeping with the spirit of this co-production, we need some support to hold some events, right? Some raise our profile and take information from stakeholders and really bring this in parallel in terms of impact. Bring this going. So that's what I've got here. I'm not sure what time. Have I gone too long in terms of time? I probably should wrap it up. Yeah. Okay. So there's another project I just won't say very much about. It's been initiated, and Giovanni is the lead on this. He has partnered with an engineer at University of Exeter, Professor Neil Vaughan. Philip is a stroke survivor that's been involved right from the start with us. The idea is to take some of these technologies to bring to bear on assessment. And specifically, we're going to focus on the Fugel-Meyer assessment And the hope is to develop a new way to do this that is less burdensome for the clinicians. That's all I'm going to say about that project, just in the interest of time. I think this is the final slide, bringing it back to impact. So I think this might form a phase one if we brought all this stuff together, taking stroke, taking nerve injury, and looking at across the board, condition monitoring, recovery profile, intervention, evaluation, rehab, and assessment. Product development and commercialization, our partners, Rescape, they want to produce a product at the end of this. They want to bring it to market. They want to develop a suite of games that can be useful for the rehab of the upper limb. And I've been talking, my former PhD student who graduated just last year is now taking up a position in Germany with this technical translation technologies company, TWT, pretty impressive company actually. And we've been talking about whether or not their interests are common here. So this flexible innovation support would allow us to bring together and do the road mapping that's necessary, identifying the partners and really bringing this stuff together and see if we can get an innovation plan formed. So those are the trajectories, and yeah, that's all I have to say. Yeah.
Yep. I was just thinking this would be great for a KTP grant or legal aid, UK, like.
Yeah.
There is money for this, right? Have you thought what are your plans?
Yeah, I think part of the motivation behind getting a kind of road mapping and some of these, I just learned that the word sandpit. So some of these meetings where we can focus on funding, I think that's where we're at, is sort of identifying that, because my knowledge of that landscape is quite limited, right? Being used to the more research oriented funders, right? Where what Innovative UK is looking for, and so I think we're at the point where we need to bring in some experts and have focused meetings and do a road mapping of this, right? But I do agree that there should be some potential here. Yeah.
At the moment. And that'll be a good introduction to lots of the things in the space around the innovation mapping. I think if you can maybe consider kind of KTP or smart partnerships is another one to think about, the mini KTP basically. Part of that pathway, Welsh Government will really like to see that as the progression from your essays. So.
Cool. Yeah, cool.
They've got this agreement between the two organisations where Welsh Government will now consider that under their innovation platform. So it's all kind of
Okay.
tied in together.
Okay. Yeah.
It's one application that goes to from the
depending on the scoring.
Right.
I think in terms of the sort of sustainability bit, I feel the kind of cutting down the emissions of stroke patients driving things like that. I think where there's maybe better angle on sustainability is like making rural communities sustainable to live in.
Yeah.
So being able to provide services affordably to cut off remote areas. There's clearly a sustainability argument.
Yeah.
To make that. So I feel that's more compelling than a sort of just kind of air miles argument.
Yeah. That's really helpful, and that applies to North Wales.
Again, on these Senate kind of priority of this, I think along with some sustainable communities is one of the things they're interested in.
Yeah.
Actually, that's the kind of argument you make. So if you want to provide stroke care to people on NT,
Yeah.
that's huge. If you've got effective telemedicine.
Yeah.
So I would kind of, that's one way you can certainly go with the whole thing, would be around kind of telemedicine kind of.
Yeah, that's super helpful. Yeah. I could see how that's a better angle. Yeah.
Fantastic. games being developed in the Welsh language.
Yeah. That's also a really important point. Yeah.
Unless they're non-verbal.
Well, you haven't got that far. It's a good point, though. Maybe they could be largely nonverbal. I mean, a lot of the patients have cognitive problems too, so there's a usefulness there, right?
Because they're available to any.
Yeah. I mean, this technology is kind of crazy that you could actually put the therapist with them, right? Like, so the therapist puts a headset on, they put a headset on thousands of miles away, and they're with them. And they have and they could do the kinds of things that they do in therapy to some extent, right? Like copy my movement, right? And the avatar does this, and they do that. It's pretty powerful, I think.
Fantastic. So